Right, welcome everyone to our university seminar series on addressing dementia across the public health spectrum. Today we are lucky to have Loretta DiPietro presenting for us on modifiable risk factors associated with dementia. Dr. DiPietro is a professor in the Department of Exercise and Nutrition Sciences, the Milken Institute School of Public Health at the George Washington University. Dr. DiPietro received her training in epidemiology at Yale University. For nearly 3 decades, her research has focused on physical activity and has worked very hard to combine the two disciplines of epidemiology and physiology to better understand the mechanistic underpinnings of the activity and aging. An accomplished and widely published researcher, she has awarded numerous grants from the National Institutes of Health and American Cancer Society and has been invited to lecture around the world. She is a current fellow of the American College of Sports Medicine and the former editor-in-chief of the Journal of Physical Activity and Health. In 2016, Dr. DiPietro was appointed to the United States Department of Health and Human Services 2018 Physical Activity Guidelines Advisory Committee and served as a chair of the Subcommittee on Aging. In June of 2017, she received the American College of Sports Medicine Citation Award for her career accomplishments. And in 2019 was named the WHO Physical Activity Guidelines Department Group, in which she chaired the subcommittees on aging and pregnancy. Dr. DiPietro is a former Epidemic Intelligence Service officer in the commissioned corps of the United States Public Health Service. She joined the GWSPH in 2008 from Yale University School of Medicine, where she was associate professor of epidemiology and public health and an associate fellow at the John B. Pierce Laboratory. So please join me in welcoming Dr. DiPietro.
Thank you, everyone. It's a pleasure to be here. This area of dementia is new for me, and this institute has been so welcoming and encouraging, and so I'm pleased to be giving this this seminar. And today we'll talk about modifiable risk factors for preventing dementia. I don't have to remind anyone in here the global demographics of aging. What you see in front of you in both developing countries as well as developed in orange is this curvilinear upward trend in the number of older people we can expect to be living around the world. And I need to add that at least in higher income countries, the fastest growing demographic subgroup are people age 90 or over. So we all know the implications of that for economy, for public health. You know, about 11% of at least Americans over age 65 have probable dementia, and 11% have possible dementia. And just like everything else, due to these aging demographics, these estimates are expected to increase by 2050. And this has significant consequences for the health and function of older people, not to mention their families and the healthcare system. Dementia impedes daily functioning, and it costs Americans a tremendous amount of money each year. So about 40% of dementia can be attributable to these 12 modifiable risk factors. This is a multifactorial disease. The Lancet Commission has expanded the number of factors from 9 to 12. What I have here in red are the new factors that were added. We heard about hearing loss in our last seminar, and next week we'll hear about physical inactivity or physical activity. I'm going to focus more on the other factors, modifiable factors. So the Lancet Commission has taken a life course approach to preventing dementia and outlines a number of strategies for prevention early in life, during midlife, and then later in life. And we do something similar with bone health and physical activity. You know, what are the factors early on that promote bone or cognitive accrual? What are the factors in midlife that then help people maintain their bank account, right? And then what are factors in later life that attenuate the decline in either physical or, in this case, cognitive function? We like to say that successful aging starts in utero. And so when I talk about early life, I go down to childhood. So the commission also, in this very comprehensive report, discusses population attributable risks, right? And as you all know, this is the proportion of incident dementia, in this case, that can be attributable to these risk factors, these 12 factors, right? And so you know that in addition to the relative risk, the size of the effect, population attributable risk really depends as well on the prevalence or the spread of a given risk factor. And if we look at, for example, lower education, you see that those having a low education have about a 60% higher risk of dementia compared with those having higher levels of education. But the prevalence of low education, at least in the US, is pretty high. So, you know, unadjusted population attributable risk for low education is, you see over here, 19%. In any case, you can look down these factors, right, and look across to the unweighted and weighted population attributable risk and see which of these have the greatest impact. You know, even with adjustment, low education accounts for 7% of incident dementia. And so these are weighted according to, you know, communality, which is like a clustering of other risk factors. So this gives you a good idea of, you know, the impact that these factors have on incident dementia. So with regard to prevention, I'll discuss two different pathways. One is more physiological, one is more social in nature, right? So one is preventing neuropathology in the first place, and the other pathway is through increasing and maintaining cognitive reserve. So let me talk about this neuropathological pathway. It starts here, right? And this is where these risk factors really play a significant role. These three factors, obesity, hyperglycemia, and hyperinsulinemia, all by themselves, but together, right, cause such dysregulation in numerous metabolic, inflammatory, and oxidative pathways. And you see some of the dysfunction listed here, right? This cardiovascular dysregulation, which then in turn creates havoc in the blood vessels with brain blood flow, brain volume, but also the clearing out of these proteins that relate to neuronal health, right? And this is all related to a downward cognitive decline. When you add these modifiable risk factors in there, each one of these demonstrates an independent effect with cognitive decline. But these things rarely occur independently. They're usually clustered together. And so now we talk about cardiometabolic clustering of factors and how that impacts dementia risk or any other type of risk. So the American Heart Association, about more than 10 years ago, came up with Life's Simple 7. These modifiable factors that together really influence ideal cardiovascular health. And we all know what they are. Don't smoke, eat a decent diet, follow dietary and physical activity guidelines, have a healthy body mass index, keep your fasting glucose under 100, cholesterol over 200, under 200, and have a healthy blood pressure. Here's a study with a 25-year follow-up. This is the Whitehall cohort study, right? And what they did was go back through records and create a cardiovascular health score based on the Simple 7. And so this score was for each of these factors, you got a score of 0 if you really didn't meet the criterion. You got a score of 1 if you met the healthy criterion, and you got a score of 2 if you went above and beyond the call. And then the scores were averaged over the Simple 7 to come up with a health score ranging from 0 to 7. And here you see the distribution of that cardiovascular health score on the left. Dementia risk was then modeled on this score. The overall hazard ratio you see over here for every point increase in this ideal health score, in dementia risk decreased by about 11%. And if you use a score of 9 as the reference group, which is what they did, you see those over on the left with a very poor score. Look at the excess risk of dementia over here. And then that drops as your cardiovascular health score improves. And the higher scores are actually protective from dementia risk, but unfortunately there's fewer numbers out there. Now, what's important here is, 25 years later, this hazard ratio, overall ratio, remained intact even among people who were free of cardiovascular disease. And this is important because that means this clustering is an independent of frank cardiovascular disease. So keep your numbers low, people, or keep your risk score high, your healthy score high, and really address those risk factors. So I'd like to spend the majority of this talk talking about building and maintaining cognitive reserve. This is a newer area for me. I learned a tremendous amount from putting together this talk, and I really want to take a public health perspective here. Most of these issues we in public health realize come from a basis. Most of our health disparities, doesn't matter what it is, racism, discrimination, poverty, and dementia is no different, right? These isms tend to interact and really have a huge impact on the trajectory of aging. So I've highlighted the 4 areas that I'd like to address with the red boxes. The first area I want to talk about is this one of cognitive reserve. I mentioned, with bone health, how do we promote maximum cognitive accrual? And then how do we maintain it? And then how do we prevent its decline? And we can talk about cognitive reserve the same way we can talk about physiological reserve or one's fitness level. And so these 3 factors tend to comprise cognitive reserve: educational attainment, occupational complexity, right? Staying employed. Many studies have shown that people who are retired have lower cognitive function than their peers who remain in the workforce. And then thirdly, later life engagement in cognitive intellectual activities, right? So these 3 factors tend to comprise or factor into cognitive reserve. So here, the first study I want to show you is a study among community dwelling older adults living in China. Median follow-up time was 5 years. And this study measured late life intellectual activities and reading books, newspaper, magazines, board games, and my personal favorite, betting on horse racing. So other social and recreational activities were measured, but late life intellectual activities was the major study variable. And here, these are people, the healthiest of the cohort, right? So after excluding participants who developed dementia within 3 years after baseline, these are the odds ratios for intellectual activity, both the unadjusted and the fully adjusted model that adjusts for the other activities simultaneously. So here you see, even in the fully adjusted model, those participating in such activities lowered their risk of dementia by about 29%. And over and above all other types of activities, although some of these other activities included things like watching television. So this was an encouraging finding. And again, look at it, it adjusts for education and all of these very powerful predictors of dementia risk. But there's some indication that education results in some type of reverse causation, meaning that people with higher intellectual capability tend to attain more education, achieve higher occupational status, and engage in more cognitive intellectual activities. And so it's really this intellectual capacity that should be investigated. This, as you all know, depends not just on genetic acquisition, but environmental determinants as well. So this is a study of Air Force veterans. I hate this thing. Air Force Vietnam veterans, and where general cognitive ability was measured. This is a very nice example of a retrospective cohort study, right? So these are male veterans, twins actually, who were enlisted for this study in their 50s and then followed over into their mid 60s. And so general cognitive ability, they went back to Air Force records to their qualification exam. So they had those data at age 20 and then measured it again at age 62. And so on the left, these are the various cognitive domains of interest. And along the top are some very important predictors of cognitive ability. And I have this circled because cognitive ability, general ability or endowment really was the overall strongest predictor. Here, CGA at age 20 predicted about 40% of the same variable at age 62, but even significantly predicted all these other domains of cognitive ability, and much stronger prediction than education, occupational complexity, and all of these important factors. In fact, it explained about 10% of the variation in these other cognitive domains, whereas these factors, lifetime education and everything moving to the right, really only explained about or less than 1%. So this really has to be considered in epidemiologic studies of dementia. And so now let's talk about traumatic brain injury. Again, another absolutely modifiable factor that has more increasingly public health relevance. You know, mild traumatic brain injuries as concussions, but we also deal with very severe TBIs, skull fractures, things resulting in swelling and injury and bleeding. And these are important because this is what relates over here to this hyperphosphorylation of the tau proteins, right? It results in these tangles, these bundles of crusty tangles that really interfere with neuronal integrity. The Lancet Commission performed its own meta-analysis of dementia risk due to midlife traumatic brain injury. And here I have circled the summary estimate, if I could find the pointer, over here. And these suggest that those suffering a traumatic brain injury midlife had an 84% higher risk of dementia compared with those having no TBI. Here's a study from 500,000 Swedish citizens age 50 or older, right, who were followed for 30 years. And what you see here that I have circled, right, the overall odds of dementia, again, it mirrors what I just showed you from that meta-analysis, 80% higher risk. But what's really scary is the highest overall risk of the next line is within a year out of the TBI. Dementia risk within that first year increases 3.5-fold. That's really scary, right? And then it remains statistically significant 30 years over follow-up. So this is a potent risk factor. And again, adjusted for everything important. What's more concerning and most interesting to me is this dose response relationship found in the same cohort. And here you see the odds of dementia increase in a linear manner, right, with increasing severity of TBI, so mild, severe, and then multiple TBIs. This is most disturbing to me, this study of military veterans, right? And here, what you see is the cumulative incidence of dementia based on the severity. And what you really need to focus on is this turquoise line. And what age is across the bottom is age and dementia diagnosis. And so in public health terms, look at them. I mean, this is so sad, right? Dementia diagnosis at these young ages and the level of burden, right? Not just, with moderate to severe TBI, but then across the lifespan, right? So this is the most disturbing slide, I think, that I've come across. And indeed, among those overall, those suffering a moderate to severe TBI increased their risk of dementia over 3.5-fold. The hazard ratio is 3.77, and extremely statistically significant. So if you remember anything else, this is what war does right here. And this is the burden it extols, at least with regard to cognitive health in our veterans. Now I'd like to talk about air pollution. This is a study among, oh my goodness, like over 2 million Canadians, right? Apparently Canada, especially this area of Ontario, has the lowest air pollution in the world. And so this, I think, findings from this study are quite meaningful, right? And so overall, the population attributable risk due to particulate matter, small particulate matter, the PM of 2.5 microns, 6% of incident dementia could be attributable to that exposure. And when it was adjusted again or weighted for communality, that attributable risk drops to 2.3%. If you look, these are the different models coming down on the left, right? And these bottom models really adjust for even pre-existing brain injury, stroke, diabetes, etc. There's still a bit of an excess risk due to air pollution, specifically the small particulate matter, an increase of 4%, and an increase of 10% with regard to exposure to nitrogen dioxide. Not so much with regard to ozone. Again, seemingly small effects here, but you've got 2 million Canadians. I mean, but look at what is in the model. So this gives some, relevance to the importance of studying air pollution. this is a newer study that describes the burden of dementia-specific mortality that's associated just with this small particulate matter. And again, these are veterans followed for 10 years. And air pollution accounted for about 8% of dementia-related mortality could be attributable to air pollution. Here you have the rate and the age-specific rate of dementia. Now, you know, there's issues in 2016, Melinda and colleagues published this wonderful systematic review and really highlighted and underscored some of the methodological concerns with regard to the effects of air pollution on dementia risk. Like a lot of environmental exposures, some of these things are hard to measure. Right, we're better and better at measuring air pollution in the environment, but we're never quite certain what is, you know, reaching the subject at the biological level. And I'll talk more about Melinda's group with their subsequent review, but this is a systematic review from 2019, and I like it because I kind of like the graphics. It summarizes quite nicely for me, you know, what these studies have reported. And what you see, most of the effects have to do with the small particulate matter of 2.5. The results, these on the right are studies that report an increased risk, right, for both particulate matter and nitrogen dioxide and nitric, I don't know what's wrong with my tongue today, not so much for carbon monoxide or ozone. You kind of see for some of these things, the results go on both sides. Some studies find no decreased risk or no effect at all, or decreased risk or no effect at all. So, you know, some of these findings are equivocal. It's hard to be confident in the findings. And this is the latest systematic review by Melinda's group, Melinda and colleagues, right? This is 2021. And again, they cite, you know, a number of methodological issues, you know, having to do with how you diagnose dementia, selection biases, who comes into different studies, control of a number of variables that remain in the biological pathway, right, that may attenuate the association between air pollution and dementia. And so they report findings from the 35 studies that met very strict quality criteria. And, you know, those high quality studies do support an adverse association between at least the small particulate matter, 2.5 microns, and dementia risk. And some of the other studies of lower quality and studies involving nitrogen dioxide, nitrous oxide were more inconclusive. So thank you, Melinda, for that contribution to science. And like, as I said, a lot of things with environmental exposures, there's a lot of noise. Secondhand smoke can also be considered an environmental exposure. And approximately 35% of non-smoking adults and 40% of children may be exposed to secondhand smoke. I know I was growing up, the car with the windows open and person smoking nonstop. These are data from the China Health and Retirement Longitudinal Study, and these data are only among Chinese women who reported that they never smoked and who lived with a person who did smoke. And I've highlighted this middle age group where length of secondhand smoke exposure was statistically significant. These are the beta estimates. And so for every year of secondhand smoke exposure, memory score decreased. And small effect size, but statistically significant. And these findings were not significant in the other age groups. And again, these are fully adjusted models. I'd like to finish off here talking about social isolation. These data are, from census data and project that by the year 2034, older adults will outnumber children for how older adults live, how they support themselves, etc. So at least according to Meals on Wheels survey, 25% of Americans report older adults, report living alone. And 20% of them report feeling lonely, right? And social isolation, loneliness, depression, all interact and really affect health, in such a negative way, and probably associated with an extra 6.7 billion in Medicare spending per year because of the health effects of that. Here are some data from community dwelling Japanese older adults. These people were followed almost 10 years. And what you see over on the left are these social relationship indicators, right? Different domains. And so here they are individually, right? Are you married? Do you, your contact with relatives, contacts with friends, group participation, work engagement, support, blah, blah, blah. And across the top are the different hazard ratios, both in simple models, model 1, partially adjusted models, and then model 3, the fully adjusted models that simultaneously contain all of the other social variables as well as the covariates. So this may seem like a little bit of an over adjustment to me, but what do I know? But anyway, what you see here by the red arrows are the effect sizes here that are, and those that are statistically significant. So being married, contact with friends, group participation, work engagement, and family support, right? The risk, dropped from about 12% here. So then what they next did, these investigators, was create an exposure score, right? Depending on how many of those positive factors a person, a respondent had. And so that index ranged from 0 to 1 to up to 5 of those factors. And look at this dose response relationship, right? The more of those factors, social indicators that you had, right, just this beautiful, significant, decreasing graded effect, right? Whereas those that had all 5 of those important indicators lowered their dementia risk by, what is this, 46%, right? And even having 2 factors of those factors significantly increase your risk, right, by 14%. So socialization is important. It's key. And balance that against the number of older adults that are going to be in our population. This is going to have huge implications for healthy aging. And so here, I'm showing you this lovely graphic from the Lancet Commission, which talks about the attributable risk, or what can be saved or prevented early in life, right, in the green, midlife, and then later life. And so as early as possible, if we could fix this education thing, I think I said before, it accounts for about 7% of dementia risk is attributable to this. So let's fix this, let's modify this. Then through midlife, you see these factors. Their population attributable, sorry, I said that backwards. This is a preventive, more the preventive fraction, what you can, the reduction in dementia prevalence if you could eliminate this risk factor. So keep that in mind. My apologies, right? So most of these, all of these are modifiable. And this is a lovely graphic, I think, really depicting what we could save. Now, the commission also outlined some preventive strategies that are tailored toward either reducing neuropathological damage, or reducing or improving cognitive reserve, or some things that would affect both. I want to add, these are targeted toward the individual, right? So we all know, treat the hypertension, to minimize this damage, treat hypertension, wear a helmet, stop smoking, reduce your exposure to air pollution, start exercising, meet the guidelines, lay off the booze. If you have a hearing impairment, get hearing aids. Continue your education for as long as possible, and maintain frequent social contact. As I said, some of these are more directed toward a given pathway, but some of these could affect either pathway. But we're in public health, or I am. I've only worked in public health my entire career. So I tend to focus more on these policy, systems, and environment approaches to lowering disease risk. And so these approaches work more at, the policy, the systems, the environment. And rather than affecting an individual, you make these changes, you tend to affect everybody equally who comes in contact with those policies, those regulations, those environmental shifts. And so, I took the liberty of outlining some preventive strategies that should become PSE priorities, and that could really affect or lower dementia risk across the life course. And so let's prioritize education for everyone across, not just early childhood education, not just keeping people in high school or providing free college tuition. Let's make it available for anyone across their lifespan. Let's work more towards creating healthy food and built environments. I didn't talk about diet today. It's totally modifiable. Diet, the Mediterranean diet seems to be protective for dementia. That's all well and good, but when you're living in Ward 8, it may be hard to find olive oil and fresh fish and green leafy vegetables, or even sidewalks to walk on. Physical activity we'll hear about next week. Let's create healthy food and healthy built environments that can help people achieve dietary guidelines and physical activity guidelines. We need stricter laws to reduce sport, occupational, and transportation-related brain injuries, right? A lot of states still do not have motorcycle helmet laws. That needs to change, and we need to work toward creating these stricter laws, especially since the consequences of these TBIs early in life follow somebody for the rest of their life. And, we discuss, days, disability days, or work days, just potential loss. I'm forgetting my metrics here. Let's work toward creating stricter air pollution regulations, traffic laws, where the coal burning a power plant is. This is especially true in low income neighborhoods who suffer exposure the most. And maybe, as Melinda pointed out, in those systematic reviews, may be the least likely to enter your study. We need stricter occupational and environmental noise pollution regulations. Sure, the guy using the jackhammer may have earphones on, but what about everybody else? Leaf blowers, these hot rods and trail dirt bikes are becoming more and more prevalent. Let's strengthen national efforts to reduce exposure to secondhand smoke, right? It may have to go into the level of the car, the automobile, no smoking when children are in the car. And then finally, let's create more age-friendly environments, right? And what we mean, what do I mean by that? This is the focus of our next, not the next seminar, but our last in this seminar series, is to hold a roundtable discussion with our partners in the community, especially our partners, Gail Cohn and the Age Friendly DC group, our Center for Health and Humanities group, and other key stakeholders working with older people in the community. Let's, with regard to maintaining social engagement, this is so important. And we want to promote this across the lifespan. So, you know, I just put together my crusty brain, some ideas that I have, and I'm certain that other people have far more advanced strategies that they've been discussing for a long time. And I'd like us to get together to discuss how this could affect dementia and brain health. So age neutral housing, right? Whoever invented segregating houses or older adult living communities, what about mixing it up? In parts of Europe, you have older people young people, college students living with older people, matching up. Everybody wins in that situation. Let's keep promoting age neutral community events, right? Which make it possible for older people of all abilities to participate. I'm a big fan of age neutral playgrounds, where the playground equipment is appropriate for children all the way up to 150-year-olds. So everybody can play and people can play together. We'll talk about volunteer opportunities and then, you know, second career opportunities. Once you're pushed out of academia, what do? Right? You get your office put down in the basement, like on that show, the Chair. But, you know, what are some creative second career opportunities for people leaving their primary job? So again, I'm setting us up for our final roundtable discussion. We will meet in person, and it will be recorded for everyone else who is interested. So that's all I've got to say. I've left some time for discussion or questions.
Yeah, thank you for such a great presentation and highlighted so many important aspects that we really need to address. Maybe I'll kick off with a question. So we highlight that social isolation is really detrimental to older adults. Do we know how big of a role socialization plays when you're kind of in your 20s and 30s, such that, you know, we know there are a lot of effects from metabolic health at a younger middle age. Is there any protective aspect to being more social when you're younger?
Well, one of the greatest natural experiments that we have right now is the isolation due to COVID, right? And so I think a number of studies report at any age, there's more reporting of depressive symptoms, more drinking, more binging on television, and lower physical activity. So I would say social isolation at any age is bad, but particularly so as we get older. Again, it's a social isolation, but it's also that feeling of engagement that's so important, that I'm helping, I'm engaging, I'm contributing. And so that's why I went on and on about, you know, second careers. It's very important.
Hi, Loretta, that was great. This is Sharon Edelstein. I can't tell if you can see who's talking. That was fantastic. Of course, you know, what the data you showed is amazing. And, you know, Ashley and I are chatting on the side about how much we love the adult playground or the all age playground, but you're preaching to the choir. So we would all love to see these things happen. How do we make it happen? How do we make sure people who aren't getting good educations when they're young get good education? And we, you know, do install these multi-generational playgrounds, and we make sure social isolation isn't a problem, and that people don't get head injuries, right? That we all have lots of ideas about that, but this is,
yeah,
I'm thinking next steps.
Yeah, so right, so next steps, which is why I put out those policy, system, environmental priorities. And so you know, it usually can't be done at a national level. It works, these strategies tend to work best locally, right? Where you have a dedicated group that is really pushing. And, you know, the age-friendly DC folks, Gail Cohn's group, I mean, it's just such a wonderful model of taking, you know, environmental and policy approaches to making Washington, DC an age-friendly community. So lots of different people involved that have different outcomes of interest, right? You know, employment, housing, transportation. And so it really is, it has to happen at the PSE level. And yeah, these things have to become a priority. And as you know, public health priorities tend to shift depending on who's in office. So Sharon, that's a great question.
It looks like we have a couple more questions in the chat. One of which is, with the points that you highlighted, are there differences between men and women that you could highlight?
Well, women are most at risk, more so than men. And, you know, is this a biological thing? That's not clear. Or, you know, the oldest women that we study didn't have the same education as men did early on. This is especially true in low-income countries. A lot of these studies didn't stratify the results by sex or gender, but women tend to be at greater risk than men.
It looks like one other question was, can you talk more about the age-neutral playgrounds?
Oh, yeah. This is my big fantasy as I turn 65. Yeah, so in our Design of Healthy Communities class and with the 11th Street Bridge Project, age-neutral playgrounds have age-neutral playground equipment, right? Rather than these climbers and slides and swings that, you know, cater only to little kids, these age-neutral playgrounds has equipment that, you know, anyone can use, right? So an older person could be on a piece of equipment with their grandchild or with another older adult. How much fun would that be, right? And so if you just Google image age-neutral playground equipment, you'll see what comes up. And I know that with the 11th Street Bridge Project, they are working toward their playgrounds and park spaces around that to be age neutral. I'd be the first one there on work time.
I'll be there with you. So seeing it's a little after 1 o'clock and we answer the questions in the chat. Thank you very much, Loretta, for this excellent presentation. And I just want to remind everybody that Victoria put information for our next seminar in the chat, but it should be on February 16th, and we'll have Dr. Kirk Erickson from Pittsburgh talking about the role of physical activity in brain health. Let's everybody give Loretta a round of applause, and hopefully we'll see you next time.
No, thank you, everyone. Thank you for coming.